issue, but that is a crucial issue. In the UN system, those types of things are often handled by other UN agencies like, I would say, UNHCR. Sometimes, I don't know if the World Food Program, but UNHCR would also be involved because they're involved with protection and shelter as well. But we all work together on these things. We have an interagency working group. So, yes?
Very short. My name is Jerry Breers from Amsterdam. What's your positions towards religious organizations who have other ideas than your organization?
Thank you. That's challenging, and it's a very timely and controversial issue. In fact, we had a few weeks ago we have our annual scientific and technical advisory group for our department met, and that issue came up. And we really seek to engage with faith-based organizations in a objective way, because they do play a role in providing health care. And I can say that on an individual level, it's sometimes easier than when you talk about the broader institutional organizational policies. As a concrete example, for this meeting we have in 2 weeks coming up, we have invited World Vision International, which is a Christian organization, and it's the major humanitarian organization, one of the major humanitarian organizations, particularly probably the major Christian humanitarian organization globally. And they're coming to the meeting, and they're talking about emergency contraception. They're talking about emergency contraception. So, these issues, a lot, there are the institutional policies, but some of the policies may be based on misperceptions. For example, with emergency contraception, there's a misperception that it is an abortification or it causes abortions. That's scientifically not true. And so if we're able to, we have fact sheets, we have all of our research papers, we have established this scientifically. However, if we're able to find a way to communicate this effectively, and it may not be from a science background, if we're able to communicate this effectively and partner, we can still move forward. So yes, World Vision is using emergency contraception in humanitarian context, and we're going to talk about it in a few weeks and how we can really support moving that forward. It is a challenge. Yeah.
Hi, I'm Juliet from Malmö, Sweden, and thank you for your great work of the WHO. I just wanted to ask you a question about women's reproductive rights. I am fertility challenged, and as an American woman living in Sweden, I uncovered some really disturbing rights that I get stripped away from by living in Sweden, meaning that as an American citizen, you would have rights to your frozen embryos because they're maternal owned, and in Sweden, they're owned by the state. So what we've uncovered is we can't move across borders with our frozen embryos. Also that you aren't seen as it's their property, they can determine the length of keeping them, and also, unfortunately, surrogacy is illegal. So I was wondering, is it on the WHO's agenda to discuss standardizing the rights of frozen embryos and also giving all access for every woman for surrogacy?
Thank you. That's a great question. I don't know if I have the technical expertise to answer that to the level that you'd probably like, but I can say that these issues are important to our department and to WHO. We have, actually my office mate at WHO, her specialty is infertility and access for global access, not just in high resource settings, but also low resource settings. And so she's just recently updated their website. Is something we talk about, and especially the rights-based approaches. It was on the agenda of our scientific and technical advisory group last month, and it is something that we are actively working on, and again, a coalition of organizations. There are many societies that are active in this, and I would assume that they have representation in Sweden. But I would encourage you. I'm happy to give you my card and can put you in contact with my colleague. But also the website has been recently revamped, and it probably could be somewhat informative. I can say that personally, when I don't do as much field work as now that I'm at WHO, I don't go to the field as much as I'd like. But prior to joining WHO, I was in the field extensively, and that was the thing that women sought. I would be in Afghanistan, Yemen, wherever, and they would say, oh, there's an American obstetrician, gynecologist who's coming, and even though I wasn't supposed to be providing services, I was supposed to be training and supporting the local staff. Inevitably, there's a line of women that want to see me, and not necessarily for a physical exam or procedure, but just to talk. And always more women with fertility issues and infertility problems or challenges, and it's a global issue, and it's about rights. It's about really, that's why we really are looking at this as a broader aspect, the entire spectrum of sexual and reproductive health. It's not just about childbirth. I can't answer your question specifically, but I can say that there are people who can answer it and that are very interested in these issues, and there is work ongoing.
Hi, Louise Copley from Eastern Province, Saudi Arabia. 10 years ago, through FAWCO, I attended a UN FPA event, and at the time they were promoting a safe birth kit, which was a plastic sheet for a woman to give birth in the, where there was no safe birth area. It was a piece of string to tie off the umbilical cord, I believe a razor blade, and a bar of soap, and these kits costs less than $1. And I was just wondering, is that still a standard protocol to issue to humanitarian groups?
Thank you for raising that question. There is a lot of controversy on that topic, and actually I'd like to just clarify the terminology. What you're describing, we, at least at WHO, we don't necessarily call that a safe birth kit. We call it a clean delivery kit. And I think there's a lot of misperception around these kits. Sue Ellen used to say to me, there are kits and there are kits. That particular kit or package, and actually we're calling it now as more of a package, because it is exactly as you've described, and it is just a few essential supplies, and it's for women who don't have skilled birth attendants, and there are really a very exhaustive evaluation and studies done on this intervention in a number of low-resource settings, Nepal, a number of places, Bangladesh, etc. And a paper was issued a few years ago on the clean delivery kits. And the outcome, again, is a very well-done study through academic institutions, Save the Children, etc. It's the University of Aberdeen, which is the big impact initiative. So these were very rigorous compilation of evaluations, systematic reviews, etc. And what we understand is that these clean delivery kits really only have an impact on newborn outcome, particularly with regards to sepsis and newborn death due to sepsis. It does not really do anything for maternal health. And it's not something we're promoting. We are looking at programs that include misoprostol in these kits, because misoprostol is a drug which can prevent postpartum hemorrhage, so there is an idea of putting misoprostol into these again, packages, I should use the term, be careful with my terminology, into the clean delivery packages. But that was with our postpartum hemorrhage recommendations, which were revised last year. We specifically discussed those interventions, and they don't meet the level of evidence to issue a WHO guideline. So studies are ongoing, and I would say watch this space. But with regards to the current clean delivery packages which you've described, which do not include a uterotonic agent, they really only are effective for newborn outcomes. And the way forward is to include a few more things around to protect the mother. I mean, what WHO says now is that every woman who gives birth should have access to a uterotonic, full stop. And what we don't have the evidence on is, can a woman give herself that uterotonic? If she's giving, I mean, many women give birth alone. So can she self-administer that uterotonic? Yes, of course she can self-administer it, but do we have the level of evidence that it's effective, and can we issue a recommendation? I would hope that in the next few years, that evidence will be available. And there are many, many programs, U.S. Agency for International Development funds, many programs on these types of interventions. But from WHO's perspective, our guidelines are pretty clear. We're able now to go for misoprostol for community health workers, for lay health workers who are trained. But self-administration by the woman herself, we don't yet have that evidence. I hope we will.
We don't hear anything. We can continue at lunch.
Yeah, we can continue that question at lunch.
Thank you so much.